Welcome, Zoo Assembliers! My name is Zouk Azalishvili and I'm the founder of Zoo Assembly. Zoo Assembly is an online podcast for the highest yield basic science and clinical knowledge tested on USMLE Step 1 and USMLE Step 2 CK. The information discussed in this podcast is intended only for educational purposes. It's not intended to prevent, diagnose, or to treat the medical conditions in real clinical practice, nor is it intended to reflect the policy and the guidelines of various health institutions. Simply put, we serve you to butcher your step exams. Please subscribe to our podcast, Facebook, Instagram pages, and the YouTube channels down below in the description of this episode so that we keep you tuned for the news at Zoo Assembly. Now, let's start rolling. We are continuing our pediatric series, and today the first disease that we're going to cover is Kawasaki's disease. Kawasaki disease is also known as the Mucocutaneous lymph node syndrome. And guys, let's break down the word itself. I don't want us to memorize the words without knowing their meaning. Once again, the word is mucocutaneous lymph node syndrome. It means that these patients usually have mucosal involvement. They also have rash on their skin. This is what cutaneous refers to. And finally, they have lymphadenopathy. This is what the lymph node refers to in the name of Kawasaki disease. Kawasaki's disease has several very specific and distinct criteria that should be met in order to diagnose somebody with Kawasaki disease. First of all, this is a medium vessel vasculitis. At the same time, as we know, Kawasaki disease is common in children and especially those of Asian ancestry. In order to diagnose the child with Kawasaki disease, she or he should meet at least 4 out of the 5 criteria that we are going to discuss right now. First, the patient should have fever for at least 5 days. But I guess you will agree with me if I say that the presence of fever alone is not enough to diagnose somebody with medium vessel vasculitis, specifically Kawasaki's disease. These patients also commonly have the cervical lymphadenopathy, and the cervical lymph node should be more than 1.5 centimeters in diameter. Additionally, as we already mentioned in the beginning of this discussion, these patients have mucosal involvement, and in this case we talk about the oral mucosa and also conjunctiva. Patients with Kawasaki disease commonly have so-called strawberry tongue. And strawberry tongue is the tongue with these red dots that represent the lingual papillary hyperplasia. If you remember from the basic histology, there are different types of papilla on our tongue, and their hyperplasia gives the tongue the appearance of the strawberry. They might also have the lip cracking. And as for the eye involvement, children with Kawasaki disease commonly have the bilateral conjunctivitis with no exudate, because this is not an infection, right? This is, again, medium vessel vasculitis. And finally, the patients with Kawasaki usually have the rash, which is desquamating, and they also have the swelling of their hands and feet. Again, if the patient meets at least 4 out of these criteria that we discussed, then we can say that the patient has Kawasaki disease. Let me give you a question, guys. Do you remember how we treat the Kawasaki disease? Are you saying aspirin and IVIG? If you are, that's totally right. We give aspirin to these patients because we want to prevent the coronary artery complications. let's remind ourselves from the basic anatomy that the coronary arteries are the medium-sized arteries. Therefore, Kawasaki disease can involve the coronary arteries, and the common complications in regards to the coronary arteries is either coronary microaneurysms or coronary thrombosis leading to myocardial infarction. Can you imagine a child, little child, usually less than 5 years old, with the classic signs and symptoms of MI? This is very characteristic of Kawasaki disease. I wouldn't say that it's pathognomonic because there are other conditions which lead to hypercoagulable state in early life. However, coronary microaneurysms, along with the high risk of myocardial infarction, is definitely accompanied with Kawasaki disease. And aspirin, okay, let me ask this in a question format. How does aspirin work on our hemostasis? That's right. Aspirin inhibits the cyclooxygenase 1 in the platelets, and again, this is an irreversible non-competitive inhibitor of cyclooxygenase, and therefore we decrease the production of thromboxane A2, and therefore we decrease the platelet aggregation. And the thrombus is first formed by the platelet aggregation. This is how we protect the children with Kawasaki disease from the coronary thrombi. And then IVIG is also administered. However, nobody really knows the exact mechanism of how IVIG improves the prognosis in patients with Kawasaki disease. Okay, so this was discussion about the Kawasaki disease or mucocutaneous lymph node syndrome. Now let's briefly discuss the labial adhesions. The labial adhesion, as the name implies, is the adhesion of the labia minora to each other. So like two labia minora, they are adherent to each other. This commonly happens in prepubescent girls, and the reason here is possible pathophysiology of labial adhesions is the relatively low levels of the estrogen. The complications that labial adhesion can produce is that it increases the risk for UTIs. You can imagine that if labia minora is adherent, then the urine cannot flow normally while the girl pees. And this is when the urine can undergo the backflow in the urinary tract, and this can definitely grow into the urinary tract infection. The way we treat the labial adhesions is to apply the topical estrogen creams, because when we apply the topical estrogen, this ointment will basically disintegrate those two labia minora, and then we will receive the normal anatomy of the female vulva. So this was a very, very brief discussion about the labial adhesion because there is not much to talk about it. However, we should definitely know how we treat the labial adhesion, which is topical estrogen. Now we will discuss the Laryngo Militia. Again, just as we do in the beginning of almost all diseases, let's break down the name. Laryngo Militia. Militia means softness or weakness. Laryngo means larynx. So Laryngo Militia is laryngeal weakness. And specifically, this disease is caused by the weakness of the floppiness of the laryngeal cartilages. Normally, let's take the normal situation in a healthy human. When we inhale, the larynx maintains its normal patent shape thanks to the laryngeal cartilages. For example, we have those arytenoid cartilages, if you remember, on the backside of the larynx. But in infants with Laryngo Militia, those arytenoid cartilages are weak and floppy. Therefore, when we start inhalation, at the mid phase of the inspiration, those cartilages will be dragged towards the center of the larynx, and they will partially, or in rare cases, completely obstruct the larynx. In other words, there will be an obstruction or narrowing at the level of the larynx during the inspiration. And this will cause the inspiratory stridor, because if you remember from our step 1 respiratory lectures, we have mentioned there that the stridor is due to upper airway narrowing, and the larynx is definitely above the trachea. It's very high yield to know that stridor in infants with Laryngo Militia usually improves with the prone position, but it worsens with the supine position. The idea here is that the gravity exerts its effect on those laryngeal cartilages, and whenever the infant is lying on her or his back, then the gravity effect is even larger, even greater, and this further facilitates laryngeal cartilage collapse. However, if we hold the infant in the prone position, then the laryngeal cartilages won't collapse on each other, and therefore the stridor will improve. Now, let me tell you one thing. We have not said that we should lay the infants in prone position. Actually, infant lying in the prone position has a very high risk of the SIDS because he or she might get asphyxiated if the nose and the mouth are compressed against the mattress. What I'm saying is that if we hold the baby in the prone position, this is when we will notice the improvement in the stridor in the patient with Laryngo Militia. Laryngo Militia is usually self-resolving condition, and if the stridor is mild, then the best next step in the management of the infant with Laryngo Militia is active observation and reassurance. However, if stridor is very severe, or if Laryngo Militia does not resolve on its own within the first year of life, then we can do the surgery, which will straighten up and which will strengthen those laryngeal cartilages, and this will resolve the patient's condition. Laryngo Militia is commonly compared against the additional aortic arch. This is when the aortic arch, which is normally present in all human beings, has an additional branch, and that branch compresses the trachea and esophagus. In fact, I'd like you to imagine the two vessels between which the trachea and esophagus are compressed. One of these vessels is the normal natural aortic arch, and the second vessel is the additional aortic arch. The pathognomonic characteristic of additional aortic arch is that when the child extends his or her neck, this is when the stridor will improve. The reason here is that when the child has the neck in the normal position, or when the neck is bent forward, this is when the additional aortic arch compresses the trachea the most. So if the child extends the neck, then we will relieve that compression of the trachea. Okay. and we have talked about the Laryngo Militia. Let's now discuss the lower extremity alignment. Generally, when we see the bowed legs or the knock knees, we tend to think that these shapes of the lower extremities are always pathological, but this is not true. There are certain ages in the development of a child when the Genuvarum or the bowed legs and Genovulgum or the knock knees are normal. And this is what we are going to talk about in a second. Approximately at the age of 6 months, it is normal for the infant to have the Genuvarum. At the age of around 6 months, Genuvarum is not considered to be pathologic, and therefore the best next step in the management of this infant will be parental reassurance. The infant will most likely have the straight lower extremities later. At the age of around 2 years, the legs straighten up. However, what happens is that at the age of around 4 years, we receive the Genovulgum. Once again, Genovulgum is when the knees are very close to each other. Sometimes we call this condition the knock knees. And again, if the child at the age of approximately 4 years is brought to the physician by the parent complaining that her child has the knock knees, the best next step in this case would also be reassurance. Because Genovulgum at the age of 4 years can be considered normal. But after 7 years, this is when the legs eventually straighten up. And so if either Genuvarum or Genovulgum persist beyond the 7 years, this is when we can already start thinking about the pathological causes of these lower extremity conditions. One more thing. When the infant has either physiologic or pathologic Genuvarum, or the bowed legs, then there is this one phenomenon which I'd like to tell you about. It's called lateral thrust. Lateral thrust is when the knee joint protrudes laterally when the child with bowed legs walks. And this is characteristic for the Genuvarum specifically. So this was discussion about the physiological lower extremity alignment. Let's now discuss the lead poisoning in children. Before we dive deep into the clinical features of the lead poisoning, I'd like to talk to you about the risk factors of this condition. First of all, the wall paints were used to contain the lead, and if the house is built before 1978, then there is the possibility that the walls and the physical paint on the wall contains lead. Now, do we need to know this exact year for the USMLE Step 2 CK exam? I would say not necessarily, because the question will not ask the exact year before which the lead was common and the wall paint. However, it will be good if we know that too. At the same time, if the child has excessive mouthing behaviors, then she or he is at risk for the lead poisoning. In mouthing behaviors, I mean the child putting everything into the mouth. And this is the normal habit for the infant and also for the early toddler. However, sometimes it might be very excessive. Additionally, if the child has psychiatric condition called the pica, then that child is also at risk for the lead poisoning. Guys, do you remember what pica is? I'll give you a second for that to think about. pica is psychiatric condition and eating disorder when the patient eats the non-food substance which is inappropriate for his or her cultural and religious norms. For example, sometimes people with pica eat dust, soil, they might eat the ice, snow, and if the child has pica and if that child eats the wall paint from the walls, then definitely he or she is at risk for the lead poisoning. Also, if the child has a sibling with lead poisoning, it means that that child is also at high risk for being exposed to lead. Low socioeconomic status and the immigrant status are another risk factors. And finally, if the child is international adoptee, this child might have had exposure to lead in his or her initial original country. Now, how does the lead poisoning present? First, lead poisoning can be completely asymptomatic. And we might intuitively think that the degree of the lead poisoning severity depends directly on the lead concentration, but that's not necessarily true. The symptoms in lead poisoning might be abdominal pain and constipation, which is very common, and plus the question stems commonly mention the constipation as one of the symptoms of the lead poisoning. The child and any other individual at any age might also display the cognitive impairment and behavioral changes, and the child might also have the encephalopathy. Okay, now how do we diagnose and manage the lead poisoning? First, if the screening test was performed by obtaining the capillary blood, then we should confirm the lead level in the venous blood. So what I'm saying is that if capillary blood sample shows us an increased lead concentration in the blood, we should definitely follow up the capillary sample with the venous blood sample. If we definitively diagnose the lead poisoning, we should certainly perform the environmental surveillance of the patient, meaning we should identify the exact source of the lead poisoning so that after we treat the patient, he or she won't go back to that source and won't be readmitted with another episode of the lead poisoning. Lead poisoning is the condition that should be notified to the public health department, and if the child has either excessive mouthing behaviors or pica, then we should consider the nutritional rehabilitation and counseling. And finally, let's talk about the collation therapy. This is very important because Step 2 CK exam wants us to know at what lead level should we start collation therapy and with which collator should we start the therapy. Now, at first, let's divide the lead poisoning into three categories. We have mild, moderate, and severe lead poisoning. Mild lead poisoning is when the venous lead concentration is anywhere from 5 to 44 micrograms per deciliter. And if we have mild lead poisoning, then we don't actually need collation. The idea here is that collators are non-specific. They bind not only to lead, but also to the other heavy metals and the other substances which might be essential and beneficial for the patient. Therefore, the risks of giving collation therapy are actually higher than the benefits of collation therapy when the child or any patient has mild lead poisoning. Let's move on to the moderate lead poisoning. This is when the venous lead concentration is anywhere from 45 to 69 micrograms per deciliter. When we have moderate lead poisoning, this is when we give Succimer. Succimer is an abbreviation, and another name, complete name of the Succimer is meso 2,3-dimercaptosuccinic acid. We don't have to remember this big name. Succimer is totally enough. And another thing that should be mentioned about Succimer is that this is an oral therapy. And don't forget that here we are talking about the children. And for children, oral medications are the most convenient way to collate the lead. Now, if the venous blood lead concentration is at least 70 micrograms per deciliter, this is when we are dealing with severe lead poisoning. And in case of severe lead poisoning, we should certainly use collation therapy, and the agents that we are going to use here are dimercaprol, which is also known as British anti-leucite, and EDTA. EDTA is also known as calcium disodium acetate. But once again, just like we said for the Succimer, we don't necessarily have to know this long name for EDTA. Now, to summarize the lead poisoning management, we should say that we have mild, moderate, and severe lead poisoning. For mild lead poisoning, we don't have to do collation therapy, but we check the venous lead concentration in less than 1 month. For moderate lead poisoning, we give Succimer. But for severe lead poisoning, we give the dimercaprol and DTA. So this was discussion about the lead poisoning. Now I will discuss the malrotation with midgut volvulus. Malrotation is abnormal rotation of the embryonic midgut around the superior mesenteric artery. Let's recall the step 1 fact, guys, a little quick. So, do you remember between which gestational weeks we have the midgut rotation? That's right, midgut rotation happens between 6th and 10th weeks of gestation. And let me also remind you that midgut normally should rotate 270 degrees counterclockwise around the superior mesenteric artery, or SMA. Now, if the midgut rotates by less than 270 degrees, this is when we get the malrotation. And the organs, abdominal organs, might have abnormal position in the peritoneal cavity. First of all, in malrotation, the base of the mesentery, meaning the part of the mesentery that immediately holds the intestines, is very narrow. And narrow mesenteric base causes excessive small bowel mobility. And when we have increased mobility of the small bowel, this is when the small bowel can twist around its mesentery, and this can cause the ischemia and necrosis. In other words, malrotation is a chronic condition, but it can be complicated by acute condition, which is the midgut volvulus. And malrotation always carries the risk for the midgut volvulus. We have already discussed one reason for this, but there is another reason. Do you remember, guys, when I told you that some abdominal organs don't have the normal position in the peritoneal cavity in the patients with malrotation? These patients usually develop the fibrous bands called the lead bands between these organs. Lead bands are very thick, very sturdy fibrous bands which can compress the bowel segments. And if they compress the bowel segment enough, then we can also get the bowel obstruction. That can also result in the deterioration of the patient's overall status. Malrotation with midgut volvulus is most commonly seen in the infants, especially in the infants less than 1 month of age. Again, we said that malrotation is a chronic condition, and the malrotation itself presents with episodic abdominal pain and vomiting, and also failure to thrive because the infant throws up almost everything that she or he is fed with. However, if malrotation is complicated with the midgut volvulus, then we have the acute presentation of the bilious vomiting and also abdominal distension. If we don't treat the malrotation with midgut volvulus, then the ischemia of the bowel wall is the dangerous complication. And if we get the ischemia, then we will get the necrosis of the bowel wall, and this can result in peritonitis and shock. How do we diagnose the malrotation with midgut volvulus? First, we can do the abdominal x-ray. On the abdominal x-ray, we might see the dilated bowel with the air fluid levels, and we might also see the pneumoperitoneum. Let's explain these findings. Midgut volvulus means that small bowel twists around its mesentery, and then there is this segment of narrowing beyond which the fecal masses cannot go through. Proximal to that obstruction, all of those fecal masses and the secretions will accumulate, resulting in air fluid levels and the dilated bowel. But beyond the obstruction, we might have the gasless intestine, because if there is complete bowel obstruction with the volvulus, even air might not be able to pass through the point of obstruction. As for the pneumoperitoneum, this is when air escapes in the peritoneal cavity due to the rupture of the bowel or stomach. And if there is very severe bowel dilation, then increased intra-intestinal pressure can definitely perforate the bowel wall, and it can definitely cause the pneumoperitoneum, which, by the way, is an immediate indication for laparotomy. The gold standard to diagnose malrotation with midgut volvulus is the upper GI series. Upper GI series is when we give the patient barium swallow, and then we take the x-ray images to identify any anatomical defects of the GI tract. And a pathognomonic finding on the upper GI series for the malrotation is the right-sided ligament of Treitz. Here comes the question, guys. Do you remember from the anatomy what the function of ligament of Treitz is? I hope you're telling me that ligament of Treitz holds the fourth part of duodenum. So it actually holds the junction of the duodenum and jejunum. And this junction is normally located on the left side. However, if the patient has malrotation, then ligament of Treitz will be located on the right side. Additionally, the upper GI series might reveal the corkscrew or the bird's beak duodenum. The idea here is that malrotated duodenum will have the corkscrew appearance upon the barium swallow, and if duodenum is filled with the fluid and the food masses, then it will be dilated and it might look like the bird's beak. Please, let's compare these findings to corkscrew esophagus and the bird's beak esophagus. Do you remember which condition causes corkscrew esophagus? Are you saying diffuse esophageal spasm? If you are, you rock. And then bird's beak esophagus is due to... I can hear you. achalasia. However, here we are talking about the corkscrew duodenum and the bird's beak duodenum. So please compare and contrast these findings. Now, the treatment for malrotation with the volvulus is emergent laparotomy. Even if there is no ischemia yet, we should still perform the emergency laparotomy to relieve the volvulus and prevent ischemia with necrosis. But at the same time, we should also perform something called the lead procedure. Lead procedure is the laparoscopic procedure when we lyse or break down those lead bands, those thick collagen bands, and therefore we decrease the risk for the bowel obstruction and the volvulus. And this was discussion about the malrotation with midgut volvulus. Now we will discuss the necrotizing enterocolitis. As the name implies, this is necrosis of the part of the small and the large bowels. The risk factors for necrotizing enterocolitis include the prematurity and also the bottle feeding. When the baby is born prematurely, then there is high risk for her or him to develop the respiratory distress syndrome, condition that we typically call the NRDS. When the baby has NRDS, then he or she will also have hypoxemia, right? Because gas exchange doesn't happen normally across the alveoli. Hypoxemia will cause hypoxia throughout the body, and there will be decreased oxygen delivery to the GI tract as well. This can cause the necrosis of the segments of the bowel wall. At the same time, bottle feeding is associated with necrotizing enterocolitis, and mostly the prematurity is the greatest risk factor. Necrotizing enterocolitis can present very vaguely because we're talking about the infants in these section for most of the times, right? And therefore infants cannot tell us that they have abdominal pain. So necrotizing enterocolitis can present with fuzziness, decreased consciousness, vomiting, bloody diarrhea, and on the physical exam we might also have the abdominal tenderness and rigidity in the rebound tenderness in case of the peritonitis and shock. The way we diagnose necrotizing enterocolitis is by doing the abdominal x-ray. And there is one absolutely pathognomonic finding on the abdominal x-ray for an infant with necrotizing enterocolitis. Are you guys thinking of that pathognomonic finding? Are you telling me that this is pneumatosis intestinalis? That's really cool, because pneumatosis intestinalis is when there is air in the bowel wall. Normally, we have air in the bowel lumen. This is the inhaled air, part of which goes into the GI tract. However, we don't have the air within the bowel wall. And in necrotizing enterocolitis, disruption of the integrity of the small intestinal mucosa causes the air to escape within the bowel wall, and the air makes the bubbles in this gut wall. So on the abdominal x-ray, we will see those hyperlucent air bubbles within the bowel wall, and this is called pneumatosis intestinalis. Okay, how do we treat the infant with necrotizing enterocolitis? First of all, immediately we should stop any enteral feed. In other words, we should place the patient on the bowel rest, right? We don't want the patient to be fed orally, or let me say enterally, because this will stimulate the GI tract and this can exacerbate the symptoms. At the same time, we can do the nasogastric decompression to relieve the pressure within the intestines. Then we will also do the blood culture because necrotizing enterocolitis is very commonly associated with sepsis. And we want to detect sepsis as early as we can. And at the same time, we want to treat sepsis as soon as we can. For this, we will give the infant with necrotizing enterocolitis the empiric antibiotics. In other words, we won't wait for the blood culture to come back because it might take several days. And we don't have several days because the child might die even within a day. So we definitely start empiric antibiotics, and at the same time, we might need to give the IV fluids depending on the vital signs and the blood pressure and the fluid status of the infant. At the same time, serial CBC and electrolytes should be done. In CBC, we are looking for the signs of infection, for example, leukocytosis. And then if we have the differential of the different white blood cells, then we can at least suggest what kind of infection that might be. So the bacterial or viral. Mostly it will be bacterial infection, not the viral, because GI tract is normally colonized by bacteria, right? We also need to do serial electrolyte analysis. And the reason for this is that necrosis of the bowel wall can cause release of the intracellular potassium into the blood. And this can lead to hyperkalemia, right? But hyperkalemia is not the only electrolyte abnormality that we can potentially see in necrotizing enterocolitis. So what I'm saying is that I don't want you to memorize only hyperkalemia with necrotizing enterocolitis. There might also be the other electrolyte abnormalities as well. And in addition to serial CBC and electrolytes, we might also need the serial abdominal imaging. Now, when do we do the surgery in the patient with necrotizing enterocolitis? We do the surgery if the patient has bowel perforation evidenced by the pneumoperitoneum on the abdominal imaging, or we do the surgery when the patient's condition is resistant to the medical management. So let's say that we have tried everything that we could. So we are giving the IV fluids, empiric antibiotics. We have already performed a nasogastric decompression. We've placed the patient on the bowel rest, but the patient still continues to be hypotensive, and let's say lactate is high. It means that the patient is in septic shock, and we need to act very fast, preferably with the surgery. It's very high yield to understand that necrotizing enterocolitis is not treated with surgery right away. There are specific indications for surgery in patients with necrotizing enterocolitis. Once again, this is the bowel perforation or clinical deterioration despite the adequate medical management. And this was discussion about the necrotizing enterocolitis. Let's now discuss the difference between metatarsus adductus and congenital clubfoot or Talipes equinovarus. First, let's talk about the clinical presentation of each of these conditions. Metatarsus adductus gives away the reason, or let's say the clinical feature of this condition. Metatarsus adductus is characterized by adducted metatarsal bones. Metatarsal bones in the foot are the bones which are distal to the tarsal bones, so distal to those tarsal bones that we know, and then proximal to the phalangeal bones. And those bones are directed medially. So we have medial deviation of the forefoot, but one of the most important distinguishing features between the metatarsus adductus and the congenital clubfoot is that the patients with metatarsus adductus have the neutral position of the hindfoot. In other words, the tarsal bones are not deviated medially. And the Best next step in the management of metatarsus adductus is simply reassurance and possibly the foot massage when we try to straighten up the foot, but mostly it's reassurance because metatarsus adductus will likely resolve on its own. Let's compare this to congenital clubfoot, which again is called talipes equinovarus. Tali means the ankle, pes means foot, and equino means horse. In this case, what they mean is that the patients with congenital clubfoot have plantar flexion of their feet just like the horses do, right? So the horses have those plantar flexed feet. And then varus means that the feet are turned up medially. So let's imagine what happens here. We have the rigid positioning of both feet. It might be one feet as well, but mostly congenital clubfoot is bilateral. And we have this medial upward deviation of both forefoot and hindfoot. If you remember, we said that metatarsus adductus is characterized by the neutral hindfoot position, but here we're saying that clubfoot has the medial deviation of the hindfoot as well. And again, there is this hyperplantar flexion of the feet. Now, how do we manage the infant with congenital clubfoot? In contrast to metatarsus adductus, we don't use reassurance here because this is a serious condition, and if it's not treated, then it will be associated with severe functional disabilities in the child later on in his or her life. In other words, the child might not be able to walk if we don't treat the congenital clubfoot. For this, we need the serial manipulation of the clubfoot, and we also need the casting. Now, if the manipulations and massage and the casting don't help, this is when we will refer to surgery for the congenital clubfoot. So to summarize, the difference between metatarsus adductus and congenital clubfoot is that congenital clubfoot is a much more severe condition with poorer prognosis if not treated. Therefore, the active treatment is for the congenital clubfoot, while metatarsus adductus can be managed with the parental reassurance. So this was the difference between these two conditions. The last topic that we'll discuss today is nasal foreign body in children. Children, while playing with their toys, might put their toys in their nostrils, especially if that toy is small enough to fit into the nostril. And then the clinical features of the foreign body lodged in the nasal cavity depends on the chemical composition of that foreign body. If this is an inorganic substance, then inorganic substance could be completely asymptomatic, or the patient might have some very mild discomfort and mild difficulty breathing. However, if the substance that is inside the nostril is organic, this is when there is high risk for the nasal cavity infection, so bacterial rhinosinusitis, and therefore if the nasal foreign body is an organic substance, we might have this unilateral foul smelling and a purulent discharge. Another very dangerous situation is when there are the magnets or the button batteries in the nostrils. In that case, this can damage the vessels in the nasal mucosa, and this can cause epistaxis, but at the same time we can also have the purulent discharge due to secondary superinfection. Now, how do we treat the nasal foreign body? First, we should apply the positive pressure. And I know it sounds a little not weird, but well, yeah, it doesn't sound familiar, but once I explain to you the maneuver, you will all know what we are talking about here. So this is when we occlude the healthy nostril, and then we ask the patient to exhale with the affected nostril open. And this will just push that nasal foreign body out of the nostril, or at least we hope that it pushes out. We can also do mechanical extraction of that foreign body. However, mechanical extraction is very dangerous because we're talking about the children, and therefore children might be very fussy, they might be crying, and they might not sit still while we are trying to mechanically extract that foreign body. And the complication is that they might inhale the foreign body, and in the worst scenario, it might go into the airway. So the child might aspirate that foreign body, in which case we definitely need to do the surgery. But if the foreign body is very close to the orifice of the nostril, then it's safer to extract it mechanically. Let's briefly mention the complications of the nasal foreign body. We have already talked about the infection, which manifests with rhinosinusitis. There might also be the local irritation. We have also talked about the aspiration into the airway, which is the worst possible scenario in case of the nasal foreign body. And then lastly, the patient with impacted nasal foreign body might develop the nasal septal perforation, especially if the impacted foreign body is the magnets or the button battery. The idea here is that when more than two magnets are impacted in the nasal cavity, they can compress the part of the nasal septal mucosa among each other, and compression of the nasal septal mucosa can definitely perforate the septum. So this was discussion about the nasal foreign body, and meanwhile we have come to an end of our today's episode. Let's summarize everything very briefly what we've discussed today. We have discussed the multiple different topics across the pediatrics today. The main take-home points for practically all of these topics is to know that their current diagnostic algorithm, if any, and their treatment, of course. You can leave the voice message on this episode to let us know how we can improve our podcast for you. So thank you for your kind attention, Zoosemmeliers, and see you on the next episode.